We are soon to be likely using CAR Ts for earlier lines of therapy in the treatment of patients with multiple myeloma. While there's a whole array of clinical trials that are exploring CAR Ts, even as early as part of frontline therapy, and even some studies going even back to smoldering myeloma, the most immediate and real need is for us to be able to use them earlier in the course of the disease. The reason this is important is because we know as patients go down and receive additional therapies, other things happen, they get debilitated, and it's been pretty well documented now and by multiple studies. There's a significant attrition rate, meaning that patients may not necessarily have the opportunity to receive the subsequent line of therapy. So the most immediate opportunity appears to be coming with ide-cel, which will soon be reviewed by the FDA for use in patients with 2 to 4 prior lines of therapy, which will be, a significant change forward because it also would allow people to be able to think about the use of these therapies with a little bit more time and less pressure as we were currently using them, because we have been using this in patients who had very advanced disease, oftentimes with challenges in making sure they're even fine by the time they get their cells back. Later in the year, we'll have another review also for ide-cel. So it is quite likely that in 2024, CAR Ts will move one step forward towards the earlier forms of relapse for patients with myeloma. So one of the things that we are reassessing is how to determine where in the treatment, course of the disease a patient is, because historically we've talked about lines of therapy, and we've come to realize that's actually an oversimplification and something that actually creates complications of its own. The number of therapies really doesn't matter that much. What matters is what drugs the patients have been exposed and whether they would potentially be responsive to a similar agent, be that the same agent or something in the same class. So I think as we move forward into the future, it's going to be more important to describe patients according to what their predicted status is for responsiveness to the drugs, rather than which lines of therapy they are receiving. Now, in the best world, we would have biomarkers or tests we can do that would give us certainty. But I think it's going to be some time before we get there. So there is going to be perhaps some hypothesis at the individual patient level of this patient being likely or not to respond to these therapies. Now, this is very important too as well, because a lot of the patients will be treated with 4 drug combinations, which undoubtedly will include monoclonal antibodies. We'll have probably monoclonals be part of maintenance or consolidation. Certainly, patients will likely also have significant exposure to lenalidomide. So instead of having to say, well, let's just artificially create something so the patients get more lines of therapy and then, quote unquote, now they're eligible, I think the more scientific and medically appropriate thing will be to look at what are the drugs that may still provide benefit to a person. And if the answer is nothing of major significance, then the solution for that should be earlier access to some of these T-cell therapies like CAR Ts and bispecifics. Now, one of the key aspects I should mention for the earlier use of CAR Ts will be to look at their safety profile. We want to make sure that their use does not incur any significant, particularly enduring toxicities that we would have to look at. But so far, the indicators are that the balance is greatly in favor of benefit. We've seen this with KarMMa-3, we saw that with CARTITUDE-4. So we're excited about this, and I think if I were to do this interview a year from now, probably I would tell you that we're now doing CAR Ts much earlier in the course of the disease.